Okay, about alcohol and substance-related disorders. This chapter discusses the disorders associated with the complaints described in chapter 8, which you might find helpful to read first. Alcohol-related disorders will be precedent, um, presented first, followed by other psychoactive substances. So alcohol first, then other substances. So let's talk about alcohol disorders. Epidemiology. Alcohol use is declining in the UK but is still associated with high morbidity and mortality, and overall is the most harmful psychoactive substance in common use. Middle aged people are the most likely to drink dependently and to die of complications from alcohol abuse. Men are more likely to drink excessively than women. So here we have this figure. Okay. Harm to others and harm to user. Harm to others like crime, RTA, violence, child neglect, economic costs, and these kind of things. So, and harm to others like mental health, harm to user himself or herself, like mental health problems, physical health problems, death, loss of income, or loss of relationships. You have the relative harmfulness of commonly used psychoactive substances. So you can see here that alcohol has the highest rate. Alcohol, then heroin, crack cocaine, methamphetamine, cocaine powder, amphetamine, cannabis, and ecstasy. Relative harmfulness of commonly used psychoactive substances. Alcohol causes the most harm to others, with heroin and crack cocaine causing the most harm to users. When scores are combined, alcohol is the most harmful substance. So heroin can do more harm to the user himself. And crack cocaine, the same thing with amphetamine. Okay. Here we have this table that is talking about epidemiology of alcohol use. Here we have the prevalence within adults in England in 2014, 2015, or 2016, and the association with gender and age. For alcohol use in general, we have 57% drank any alcohol within the last week. This proportion is generally reducing. Association with gender and age, we have 63% of men, 51% of women, aged from 16 to 40 years, least likely to drink. What about hazardous use of alcohol, which means more than 8 units for men and 6 units for women in one day? 15% binge drank within previous week. Male to female ratio is 1:1. Age 16 to 24 years most likely to binge. So 16 to 24 are least likely to drink in general, but they are most likely to binge. What about alcohol dependence? It's about 1.4%. Male to female ratio is 3:1. Highest dependency rates in 25 to 64 year olds. What about hospital admissions related to alcohol? 7% of all hospital admissions, which about 1.1 million. So 7%. Male to female ratio is about 2:1. Most admissions in 55 to 74 year olds. What about deaths related to alcohol? 1.4% also of all deaths. 1.4 the prevalence of alcohol dependence. 1.4 is the percentage of deaths of all deaths that are related to alcohol. Male to female ratio is about 2:1. Highest death rate in 55 to 64 year olds. Okay, what about the etiology? The causes of alcohol dependence are multifactorial and are determined by biological, psychological, and sociocultural factors. What about genetic and biomedical factors? Okay, so we are talking about this, genetic and biomedical factors. Strong evidence shows a genetic component to alcohol dependence. Family studies show an increased risk for dependence among relatives of dependent individuals. Twin studies indicate that monozygotic twins have a higher concordance rate than dizygotic twins, and adoption studies indicate a heritable component. The nature of this influence is unclear. It may operate at the level of heritable personality characteristics, or it might relate to the body's inherited biochemical susceptibility to alcohol and its consequences. For example, 50% of East Asians have a deficiency in mitochondrial aldehyde dehydrogenase, leading to flushing and palpitations after small quantities of alcohol. This may explain reduced rates of consumption and dependence in these cultures. Okay. Mitochondrial aldehyde dehydrogenase. From a biomedical perspective, chronic alcohol consumption influences a range of receptors and intracellular signaling proteins to cause long-term changes in plasticity in reward pathways and to cause epigenetic changes. Some of the systems implicated are decreasing activity, downregulation of GABA systems, and increasing activity, which is upregulation of glutamate systems. Okay, so decreased activity to the GABA and increased activity of glutamate. What about the psychological factors? Behavioral models explain dependence in terms of operant conditioning, where positive reinforcement occurs when the pleasant effects of alcohol consumption reinforce drinking behavior, despite adverse social and medical consequences. Negative reinforcement occurs when continued drinking behavior is reinforced by the desire to avoid the negative effects of alcohol withdrawal symptoms. An alternative behavioral explanation is the observational learning theory, which is modeling, which suggests that patterns of drinking are modeled on the drinking behavior of relatives or peers. Family studies support that the idea that drinking habits follow those of older relatives. The presence of psychiatric, anxiety, bipolar affective disorder, depression, and schizophrenia, or physical illness appears to increase the risk for alcohol abuse and dependence. Although differentiating cause and effect can be difficult, there is also evidence linking alcohol dependence with antisocial and borderline personality traits. Possible explanations for this could include any of the following: attempts to self-medicate to relieve symptoms, the use of alcohol as a maladaptive coping mechanism, the lack of a supportive environment, impulsivity, or the lack of insight into the risks associated with the excessive alcohol. What about social and environmental factors? The cultural attitude toward alcohol affects the prevalence of alcohol-related problems. So the lower rates in Jewish societies as opposed to Mediterranean countries. Enormous cross-cultural variation in the way that people behave when drinking alcohol has been noted. For example, alcohol consumption in the UK, US, and Australia is associated with antisocial behavior and violence, while in Mediterranean countries it is generally more peaceful, suggesting that the effect that alcohol has on behavior is linked to social and cultural factors rather than solely the chemical effects of ethanol. Alcohol consumption is greatly affected by price. Strong evidence exists to suggest that the more affordable alcohol is, the more is consumed, and the more harm results. Okay, so that's it. What about, there is an association between certain occupations and death from alcoholic liver disease. The highest risk professions are members of leisure and catering trades, publicans especially, doctors, journalists, and those involved with shipping and travel. Okay. Furthermore, higher rates of dependence are noted in unskilled workers and the unemployed compared to those with higher incomes. This may be partly explained by the social drift caused by alcohol dependence. Okay, so you have this figure that demonstrates the increase of alcohol affordability that is associated with the increasing alcohol rate related harm. So here we have the affordability and the hospital discharge rates that are related to alcohol conditions and the years. So with the affordability, more alcohol is affordable, the more hospital discharge. Okay. So, okay. The frequency of significant life events increases the risk for harmful drinking, although the anxiolytic properties of alcohol are often used as a means of coping with stress. The social and physical complications of heavy drinking often lead to further stress. We've talked about assessment, clinical features, investigations, and differential diagnosis in Chapter 8. What about management? The management of alcohol-related problems varies markedly depending on the pattern of use. Advice about reducing intake may be sufficient for hazardous drinkers and can be delivered by general practitioners or any healthcare professional. See the box below for guidance on how to deliver a brief alcohol intervention. Up to a third of people with alcohol problems manage to abstain from alcohol without any formal treatment or self-help program. Okay. Dependent drinkers may require a more intensive intervention delivered by a specialist alcohol advisory service. Management of the latter group can be considered as having two overlapping objectives: the treatment of alcohol withdrawal and the longer term of a maintenance of abstinence. Hints and tips. Here we have the components of a brief alcohol intervention. Frames. Research has shown that the features below contribute to the effectiveness of a brief alcohol intervention. Remember the acronym FRAMES. F. Feedback. R. Responsibility. A. Advice. M. Menu. E. Empathy. S. Self-efficacy. Let's start with feedback. F. Frame feedback. After taking a history or using a screening tool, point out the patient's alcohol problem and or how alcohol may have contributed to their presenting complaint. Responsibility. The decision whether or not to change is the patient's responsibility. Emphasizing this is less likely to trigger resistance. Advice. Clearly state that cutting down or stopping alcohol will reduce the patient's risk for future health problems. Menu. Provide a range of options the patient can use for change, like substance diary, alternative activities to drinking, identifying and avoiding high-risk situations, attending mutual aid groups, and so on. Encourage the patient to select one or two to begin with. E. Empathy. Be warm, reflective, and understanding. S. Self-efficacy. Help the patient to feel confident they can make the opposed change. Encourage the patient to describe their ability to make the change in their own words. For example, do you think this is a change you will be able to make? So here we have frames. F. Feedback. R. Responsibility. A. Advice. M. Menu. E. Empathy. S. Self-efficacy. Okay, let's talk about the treatment of alcohol withdrawal. All clinicians need to be able to recognize alcohol withdrawal because of its high mortality and morbidity. The treatment of alcohol withdrawal syndrome is commonly termed detoxification. The following points are important. For the majority of patients, an outpatient or community-based detoxification will be safe and effective. Contraindications to detoxification in the community include severe dependence, a history of withdrawal seizures or delirium tremens, an unsupportive home environment, significant physical or psychiatric comorbidity, advanced age, pregnancy, or a previous failed community detoxification. In these cases, inpatient detoxification is advised. So again, here we have some contraindications to detoxification in the community that include severe dependence. Okay, let's just note that. Severe dependence, a history of withdrawal, seizures, delirium tremens, an unsupportive home environment, significant physical or psychiatric comorbidity, advanced age, pregnancy, or previous failed community detoxification. In these cases, inpatient detoxification is advised. Unplanned short-notice detoxification should only be undertaken if absolutely necessary, if a patient has to be an inpatient for another reason. In general, detoxification works best when it is planned in advance to allow the perpetuating factors for dependence to be addressed alongside detoxification. In order to relieve severe symptoms and reduce the risk for developing seizures or delirium tremens, a drug with similar neurochemical effects to alcohol is prescribed, usually benzodiazepines such as Sqour, diazepoxide, diazepam, or lorazepam. Initially, high doses are given, which are gradually reduced over 5 to 7 days. Okay. Medication may not be necessary if the patient has been drinking less than 15 units per day for men or 10 units per day for women, and has no current previous withdrawal symptoms. Alcohol withdrawal is a high-risk time for precipitating vernix encephalopathy, brain damage due to thiamine deficiency. Thiamine is therefore given prophylactically to those undergoing alcohol withdrawal. If a patient is well nourished and otherwise physically well, oral supplements are recommended. However, parenteral thiamine is needed if there is any suspicion of the onset of vernix. If someone is acutely physically unwell for any reason, if they are admitted to hospital, if they are malnourished, or if they have decompensated liver disease. Okay. Every time the brain withdraws from alcohol, it is at risk for delirium with persistent cognitive impairment. However, continuing alcohol also places the individual at risk for brain damage. If a person relapses after detox, it is usually recommended to wait for at least 6 months before initiating a further detox, to balance the risk for brain damage due to withdrawal versus ongoing use. Okay. Acamprosate is given in some centers because of its potential neuroprotective effects during alcohol withdrawal. Acamprosate. The books below summarize the management of delirium tremens and vernix encephalopathy. So here we have the management of delirium tremens. Emergency hospitalization essential. Physical examination and investigations through search for alternative cause of delirium associated with alcohol use, for example, infection, head injury, liver failure, and gastrointestinal hemorrhage, and assess for signs of vernix encephalopathy. Medication. Control withdrawal symptoms and reduce risk for seizures. Large doses of a drug with similar neurochemical action to alcohol, like benzodiazepines, intravenous therapy, seldom needed, also prevents and controls seizures. Follow local guidelines regarding dosage and choice of benzodiazepine. In general, dosage is symptom-driven, using Siwa, or follows a reducing regime. Only use antipsychotics like haloperidol for severe psychotic symptoms because of risk for lowering seizure threshold. Prophylaxis prophylaxis against or treatment of Wernicke's encephalopathy, large dosage of parenteral intramuscular or slow intravenous thiamine, 2 Babrinex ampules twice daily for 5 days. So we have 2 ampoules twice daily. Oral thiamine is not adequate in delirium tremens, of course. Monitoring for temperature, fluid, electrolyte, and glucose. Risk for hypothermia, dehydration, hypoglycemia, hypokalemia, and hypomagnesemia. Okay. And for general principles for managing delirium, we've talked about that in the previous chapter about delirium. What about communication? Some patients think that detoxification refers to the treatment of alcohol dependence. However, it only refers to the management of physical and psychiatric symptoms of withdrawal. Treating alcohol dependence involves addressing biological, psychological, and social factors that may have precipitated and perpetuated its development. Here we have a red flag. Delirium tremens is a medical emergency that is common on medical and surgical wards. Despite appropriate care and treatment, it is associated with mortality of 5% to 15%, estimated to be as high as 35% if untreated, emphasizing the need for prompt recognition and appropriate treatment. Make sure that you know the symptoms and management well. So, what about management and for maintenance after detoxification? Okay, about maintenance after detoxification. Remaining abstinent from alcohol is not as simple as successful detoxification. Often the period post-detoxification highlights psychosocial issues to the patient that intoxication had previously allowed them to ignore. So, this may include the reasons they started to drink to excess in the first place and the damage they have done to themselves and others subsequent to becoming dependent. For this reason, psychosocial interventions are crucial in allowing the patient to process emotional distress and to develop a new network of friends and similar experiences who are now sober. Recovery can be a transformational process with changes far wider reaching than simply achieving abstinence. Okay, about psychosocial interventions. Not all interventions are suited to all patients, but the huge range available means there will be something that meets the needs for everyone. Many interventions include assessing where a patient's motivation for change is using a Prochaska and declarement stages of change model. So it's about, this is the theoretical model of change, of behavioral change. The first stage is pre-contemplation, not thinking about change, then contemplation. When you are thinking about change, then you go to the preparation stage. Preparation, okay, when decision to make change, then the action to start making change, and then to maintenance, trying to prevent relapse, and after that, maybe that would, continue as maintenance, or we may have some relapse, return to previous behavior. So this is the Prochaska and declarement stages of change. Okay. The various forms of psychosocial intervention that have been shown to be effective in managing alcohol problems include motivational interviewing. We've talked about that in chapter 3. Cognitive behavioral therapy, focusing on cue exposure, relapse prevention work, behavioral contracting, dealing with trauma symptoms. We have mutual aid organizations like 12-step fellowship organizations like Alcoholic Anonymous, based around a 12-step program of spiritual and personal development. We have Smart Recovery, uses CBT to facilitate group self-help. And we have social support like social workers, probation officers, and citizens advice agencies may be able to help with homelessness, criminal charges, and debt. So, motivation interviewing, CBT, all of these things can be used in variable degrees according to the case. Okay. Hints and tips. For every person who drinks to excess, multiple others are adversely affected. The families of people who misuse alcohol or other substances can also benefit from mutual aid through organizations such as Al Anun. Support for families can also indirectly help the user. Residential rehabilitation communities, these are other forms of psychosocial means. These can provide intensive periods of structured holistic support, for example 12 weeks or longer in the difficult period immediately following detoxification. And we have peer support. Okay, what about pharmacological therapy? Various pharmacological strategies have been shown to be useful in the maintenance of abstinence from alcohol. They should be offered as an adjunct to appropriate psychosocial measures. We have disulfiram, which is antabuse. We have acamprosate, which is Cambral. And we have naltrexone, and nalmefene. And of course we can use antidepressants and benzodiazepines in general, but that's not recommended to the alcohol dependence per se. Okay, let's start with disulfiram. Disulfiram antabuse blocks the aldehyde dehydrogenase enzyme. Causing an accumulation of acetaldehyde if alcohol is consumed. This causes unpleasant symptoms of anxiety, flushing, palpitations, headache, and nausea very soon after alcohol consumption. It is contraindicated in patients with heart failure, stroke, or coronary artery disease, and caution is advised in people with hypertension, severe liver disease, cognitive impairment, psychosis, and personality disorder. So this is disulfiram that blocks aldehyde dehydrogenase to cause the accumulation of acetaldehyde when alcohol is consumed. We have acamprosate. Acamprosate, or Campral, enhances GABA transmission and inhibits glutamate transmission via NAMDA receptors, and appears to reduce the likelihood of relapses after detoxification by reducing craving. It is safe to use while drinking. So that's the purpose and the effect of that. It reduces craving, by enhancing GABA transmission and inhibit glutamate transmission. Okay, what about naltrexone? Naltrexone, or Nalorex, or nalmefene, block opioid receptors and appear to both reduce cravings for alcohol and, when taken in conjunction with normal drinking, reduce the pleasant effect of alcohol, therefore decreasing the desire to drink and the amount consumed. So that's it. The use of antidepressants and benzodiazepines is not recommended as pharmacological means for the maintenance treatment of abstinence from alcohol. What about the course and prognosis? Alcohol dependence has variable course and is often associated with numerous relapses. However, the prognosis is not as poor as is often thought, with around 50% to 60% of people with alcohol dependence showing abstinence or significant functional improvement 1 year after treatment. Good prognostic indicators include, these are good prognostic indicators include being in a stable relationship, employment, having stable living conditions with good social support, lack of cognitive impairment, and having good insight and motivation. Okay, stable relationship, employment, stable living conditions, good social support, lack of cognitive impairment, and having good insight and motivation, of course. People with any alcohol use disorder have an increased risk for death compared to age-matched controls, threefold in men and fivefold in women. Alcohol dependence is associated with a 12-fold increase in the risk for completed suicide, with death through accidents, cancer, and cardiovascular disease also common. Okay. So, let's talk about other psychoactive substances. In 2014, 29% of adults in England and Wales had tried recreational substances, 35% of men and 32% of women. In 2016, 1 in 12 young or middle-aged adults aged 16 to 59 years in England and Wales had used a recreational substance within the last year. Cannabis, cocaine, and ecstasy are the most commonly used recreational drugs in the UK. Use is the most common among men and among young people. Fewer than 1 in 100 people have used a novel psychoactive substance within the last year. Opioid use is rare by comparison with other drug use, but has the highest morbidity and mortality. Here we have this table that is talking about the epidemiology of substance use. So let's start with this. Here we have the prevalence within adults in England in 2014, 15, and 16, and the association with gender and age. Okay. And here we are talking about the use of drug within the last year in 18 to 59-year-old. Recreational drug use, we have 8% the prevalence. This proportion is gradually reducing. And male to female ratio is about 2 to 1, 12% in male and 5% in female. Okay. Younger people more likely to have used, 18% aged 16 to 24 years. Cannabis use, 6.5%, this proportion is gradually reducing. 37% of users are frequent users more than once a month. Male to female ratio is 2 to 1, 9% versus 4%. Cannabis dependence, it's about 2.3% of general adult population showed signs of dependence. Male to female ratio is also 2 to 1, 3.7 versus 1.6%. Cocaine use, powder, 2.2%, majority once or twice a year. Male to female ratio is 3 to 1, 3.3% in males and 1.2% in females. Ecstasy, MDMA use, 1.5%, majority once or twice a year. Male or females to female 3 to 1, 2.2% to 0.8%. New psychoactive substance use is about 0.7%. Male to female ratio is 3 to 1, 1.1 versus 0.4%. Younger people are more likely to have used these new psychoactive substances, 2.6% aged 16 to 24 years. And when you compare that to alcohol, you can notice that alcohol use is more with older adults, I would say middle-aged adults. Anyways, opioid dependence is 0.3%, male to female ratio is 4 to 1, 0.4% to 1.1%, commonest in 25 to 44-year-olds. Hospital admissions related to recreational drugs, mental and behavioral problems, and poisoning is approximately about 0.7% for all hospital admissions, about 100,000. Male to female ratio is 3 to 1, one half of admissions in 25 to 44-year-olds. Death related to recreational drugs, 0.5% of all deaths, 2,500 cases, drug-related deaths, are increasing. Okay. Male to female ratio is 3 to 1, over half of deaths occurring in 30 to 49-year-olds. 80% died via unintentional overdoses. Okay. So that's it. So let's talk about etiology. Occasional or experimental use of recreational substances is not the same as drug dependence. However, ongoing use of recreational substances over a period of time can lead to development of a dependence syndrome. Particularly drugs with a strong potential for the development of dependence, namely opioids and benzodiazepines. Using opioids for as little as 7 consecutive days can result in dependence. Dependence on any drug is associated with stimulation of the brain's reward system by increasing dopamine release in the mesolimbic pathway. Etiological factors for recreational drug dependence are not well understood, although they appear to be related to a mixture of biopsychosocial factors. The operant conditioning model described in alcohol section applies to other psychoactive substances. Similarly, price, availability, and cultural attitudes appear to be key factors influencing the use of recreational substances. In addition, social deprivation, childhood adversity, a family environment of substance abuse, conduct disorder in childhood, antisocial personality disorder, and severe mental illness all increase the likelihood of substance misuse problems. So we have social deprivation, childhood, okay, all of these things. Conduct disorder in childhood, antisocial personality, severe mental illness, okay. About assessment, clinical features, drug classification, and differential diagnosis, we've talked about that in chapter 8. You can go back to that. What about management? Management of recreational drug dependence involves harm reduction of continued use, physical detoxification if a withdrawal syndrome exists, maintenance of abstinence if patient wishes to stop using. A detailed description of management strategies regarding the use of all recreational substances is beyond the scope of this book. Patients should be directed to local substance use services run by the National Health Service or third sector staff, who will be able to direct patients toward appropriate resources. There is a great deal of information on harm reduction techniques online. Patients who are dependent on opioid tend to be seen by National Health Service resources because prescriptions are often involved in management. However, for many drugs, there is non-medication based treatment: cannabis, cocaine, amphetamines, novel psychoactive substances. People who wish to receive help in reducing use of such substances are likely to be able to find suitable support via third sector organizations and mutual aid, like fellowship organizations such as Narcotics Anonymous or Cocaine Anonymous. Key points on the treatment of opioid and benzodiazepines are described later. So let's talk about opioids. Opioid use is associated with high rates of drug related death and other health complications, such as a blood-borne viruses, infective endocarditis, and abscesses. It is also associated with a high cost of society through unemployment, crime, and child neglect. One of the primary aims when someone is opioid dependent is to minimize the harm associated with chaotic drug use. This can be achieved through a period of stabilization with long acting opioid substitution therapy, removing the patient's need to purchase illicit opioids to manage cravings and withdrawal. Here we have a table that compares the two forms of opioid substitution therapy recommended by NICE guidelines: methadone and buprenorphine. If they are felt equally suitable, methadone should be prescribed. However, management of opioid dependence is more than just a prescription. Next, we will have a table for the key areas to address: establishing a therapeutic reliance with the patient where they feel in control of their management is important. So here we have this table that is talking about opioid substitute prescribing, a comparison of methadone and bupropion. Methadone and bupropion, the mechanism, the side effects, the overdose risk, withdrawal symptoms, precipitated withdrawal, methods to prevent diversion, ceiling effects, starting daily dose, and in maintenance daily dose. For methadone, act as long-acting mu opioid receptor agonist, while buprenorphine long-acting mu opioid receptor partial agonist. So methadone is mu receptor agonist, while buprenorphine is partial agonist. Side effects for methadone, as all opioids, it causes constipation, sedation, euphoria, nausea. At doses above 100 mg per day, electrocardiogram to check for QTc prolongation recommended. For overdose risk, prolonged acting increases the risk for overdose if other depressants used on top. What about withdrawal symptoms? A few days to weeks can be there. Precipitated withdrawal does not occur. Methods to prevent diversion: supervised consumption. About ceiling effect, there is none. Starting daily dose is about 10 to 40 milligrams. Maintenance daily dose is typically 60 to 120 milligram. It should be. What about buprenorphine? We have said that it is partial agonist on mu opioid receptors, less sedating, less euphoric than methadone. Of course, it's not full agonist. It is partial agonist. It has lower risk as partial agonist, of course. Few days of withdrawal symptoms and can occur. And about precipitated withdrawal, it can occur if taken by a person with opioid dependency and circulating opioids, because it can block the usage. It block the opioids that are circulating in their bloodstream, because they are partial agonists anyways. So they can work such as they can work as antagonists actually if there is a lot of opioids there. What about methods to prevent diversion? Supervised consumption or combination with naloxone, which is an opioid antagonist, which is inactive if taken orally but blocks receptors if injected. This is Suboxone. So, what about the ceiling effects? For For buprenorphine, cannot satisfy very strong cravings as partial agonist, so it is less suitable for people using large amount of heroin. So you should know that. The starting daily dose is 4 to 8 milligrams. The typically dose is 12 to 16 milligrams daily. Okay. So what about the biopsychosocial management of different stages of opioid dependence? We have harm reduction. This is one domain. Another domain is about psychosocial intervention. And another domain is about substitute prescribing and detoxification alongside with abstinence. About harm reduction, the key actions are psychoeducation, offer substitute prescribing, consider child protection and give advice on minimizing harm to children from drug use, offer take-home naloxone kit, needle exchange, contraception, and advise condoms, bloodborne virus screening like hepatitis B, C, and HIV. Okay, about psychosocial intervention, we encourage attendance at mutual aid groups like fellowship or smart recovery, signpost to extra support if needed with housing, benefits, food, debts, signpost to training and vocational opportunities, consider motivational interviewing, trauma-specific psychoeducation or CBT, behavioral couples therapy, family interventions, contingency management, and residential rehabilitation. Substitute prescribing. Before initiation, confirm dependent use via toxicology screens and attendance in withdrawal. You consider methadone or buprenorphine according to the case. Initiate under supervised consumption. Regular review of dose titration to be sufficient to remove cravings, but not to cause intoxication, of course. Long-term aim can be stability on maintenance, prescription, or abstinence. About detoxification, minimize withdrawal symptoms by providing gradual reduction in opioid substitution therapy, for example, 5 milligram methadone fortnight. Opioid withdrawal is uncomfortable and distressing actually, although it's not life-threatening. So if required, offer symptomatic relief, but it's not that dangerous, but for symptomatic relief, that's good. Okay. These are some tips for symptomatic relief. A range of symptoms like lofexidine, alpha-2 adrenoreceptor agonist. For diarrhea, you can use loperamide. For nausea, you can use metoclopramide or prochlorperazine. For stomach cramps, you can use maybe Verine or hyoscine, butylbromide. For pain, you can use paracetamol or ibuprofen. For anxiety, agitation, or insomnia, you can use propranolol or diazepam for short term only. So in detoxification, you use what you can use to reduce these symptoms, of course. So, okay. About abstinence, encourage ongoing attendance at mutual aid meetings, encourage participation in recovery community activities like cafes, sport groups, and so on. Naloxone, an opioid antagonist, can be used to block the euphoriant effects of future opioid use. It induces withdrawal if the patient has circulating opioids. Develop a crisis plan. Ensure patient is aware how to regain rapid access to services should relapse occur. Okay. So, harm reduction, psychosocial intervention, substitute prescribing, detoxification, and abstinence. Here we have a red flag. Drug related deaths via unintentional overdose are increasing in the UK, with opioids, alcohol, benzodiazepines, antidepressants, antipsychotics, and gabapentinoids frequently implicated. Always provide a take home naloxone kit to someone who uses opioids and offer training on how to use it to the patient and those who are in close contact with them. Another red flag: when a patient is admitted to hospital, always confirm methadone and benzodiazepine doses with the dispensing pharmacy as soon as possible. Patients can provide inaccurate information. Prescribing a dose of methadone higher than the patient has actually been taken can result in death. Okay, let's talk about benzodiazepine dependence. Benzodiazepine dependence often arises iatrogenically when patients are prescribed benzodiazepines every day for longer than 2 to 4 weeks. It can also arise when patients purchase benzodiazepines illicitly. If someone is dependent on illicit benzodiazepines, they can be offered a detoxification prescription if they are truly committed to abstinence, but they should not be offered a maintenance prescription. Unlike with opioid, there is no evidence that this reduces harm. Caution must be exercised when attempting withdrawal from benzodiazepines, as it can very rarely be fatal. The benzodiazepine withdrawal syndrome may include hallucinations, convulsions, and delirium. Symptoms can emerge within hours to days, depending on the half-life of the benzodiazepine. Management of benzodiazepine withdrawal involves initially converting drugs with a shorter half-life, like lorazepam, to drugs with longer half-life, usually diazepam. Doses are then reduced very slowly by around 8 every fortnight, depending on patient response. If withdrawal symptoms emerge, the rate of reduction can be slowed, but increasing the dose should be avoided if at all possible. So, that is the case here. Hints and tips. Sudden discontinuation of a patient's long-term sleeping tablet when they are admitted to hospital can lead to a withdrawal syndrome. Only consider this if the patient's condition means benzodiazepines must be avoided, and ideally reduce the dose gradually. What about the course and prognosis? Mortality in heroin users is 12-fold that of the general population. Alongside a study in the USA found that after 2 decades, 28% of male heroin users had died. 18% were in prison, 23% were still using, and 29% were abstinent. So we are getting back to talk about opioids. Okay, anyways. So mortality in heroin users is 12-fold that of the general population. A longitudinal study in the USA found that after 2 decades, 28% of male heroin users had died, 18% were in prison, 23% were still using, and 29% were abstinent. The median duration of opioid use is 10 years. As with alcohol, relapse rates following detoxification are high and are more likely to succeed with psychosocial support in place. A quarter or a third of people entering treatment achieve and maintain long-term abstinence. Okay. So, we are here reaching the summary of this chapter. Alcohol is the most harmful psychoactive substance in common use. Alcohol and substance problems are more common in men. Alcohol withdrawal is a potentially fatal condition that requires treatment with benzodiazepines and thiamine. Management of all alcohol and substance use disorders requires psychosocial interventions. Mutual aid is a key component of maintaining abstinence for many people dependent on substance. Harm from opioids is reduced by opioid substitute therapy. So that's it. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.